Thank you, respected chairperson and my dear friends. The topic which I'm going to discuss today is plate to pancreas. I think it's a common saying, we are what we eat. So similarly, let's try to discuss how does your eating habit affects your pancreatic function, or how is that you are able to control your blood sugar with diabetic nutrition. Because that is one of the very important topic in a day-to-day practice, because whatsoever prescription give to the patient, final 3 words from the patient is நான் என்ன சாப்பிடலாம் இல்லை என்ன சாப்பிடக்கூடாது. But for us, if we are seeing 100 patients, we are hearing the same question 300 times. Each patient asking 3 questions in nutrition, so it's very difficult. So if you have some simplified form, it becomes very easy. So this is the agenda of my talk. I would try to discuss how this nutrition plays an important role in pathogenesis of diabetes, and what are the dietary patterns like Mediterranean diet, low-carb diets, and what exactly is this plate method in the management of diabetic nutrition, and a word about macronutrients and portion control and meal timing, and how do you integrate your nutrition with the pharmacotherapy. I think that is most important. That's one area where your nutritionist really fails, because they may be very good in nutritional management and we may be very good in pharmacotherapy, but unless you integrate both, we may not be able to achieve what is required for our patients. So in this context, what is the effect of plate on pancreas? When I say effect of plate on pancreas, it's what we eat. And we know overnutrition, which leads to chronic caloric excess, coupled with physical inactivity, leads to obesity or increased visceral adiposity. And this in turn causes increased free fatty acid and pro-inflammatory cytokines. We know visceral fat is metabolically very active, and which leads to various inflammatory cytokines produced, which in turn causes impaired GLUT4 translocation in skeletal muscle, what we call it as skeletal muscle insulin resistance. So your glucose uptake is decreased. You have insulin resistance at the level of liver, where you have unsuppressed gluconeogenesis, so you have more and more of endogenous glucose which is produced, and of course you have more and more of circulating free fatty acids. So ultimately all these things in turn causes lipotoxicity, ectopic fat deposition, and this coupled with the beta cell dysfunction causes hyperglycemia. So now this is the area where we are seeing most of our patients with diabetes or hyperglycemia. So the clinical implication or the target of medical nutrition therapy is we should try to reduce the visceral adiposity. So where you require energy deficit, we should try to reduce ectopic fat, because reducing the ectopic fat of 10 grams in your pancreas can even reverse your diabetes. We have data from direct trial or various nutritional intervention trials which have shown more than losing weight, losing a ectopic fat deposit in your pancreas, you would be able to reverse your diabetes also. And of course, we are in a position to blunt your postprandial spikes so that you are able to reduce the glucotoxicity. So this is how your nutrition plays an important role in the pathogenesis of diabetes, and what are our key objectives in your medical nutrition therapy. We have various diet plans which is available. You have Mediterranean diet, where you have a strongest evidence which suggests it has reduces a MACE risk and which has a adequate glycemic control. But which is predominantly a plant-based diet, which is rich in olive oil, nuts, legumes, fish, and we have limited red meats. But basically these studies and trials have shown there is a 30% relative risk reduction in MACE events, and there is a consistent benefits in type 2 diabetes subgroups. But when you try to look at diabetes, the more stronger evidence what we have is for the low carb diet. When I say low carb diet, your carbohydrate percentage in your meal is less than 45%. Normally, most of the carbs what we have been taking in our diet is roughly around 60 to 70%. I think that has to be reduced to less than 45%. So once when you reduce the carbs, it has to be compensated by your proteins and fat. Always minimize your sugars and starches. So the key outcome in low carb diet is where you might reduce your HbA1c, you reduce your triglycerides, and there could be a modest increase in your HDL cholesterol. We have again various data, randomized control trials, and even ADA standards which have shown that's a greater A1C reduction at 3 to 6 months, and this affects attenuates after 2 years, because it's very, very difficult to follow this low carb diet for more than 2 years or practically in the long term. Now again, diabetic nutrition, you have various food pyramids which is available, where your starches form the base, then your fat, veggies, milk, and then your fruit and your sweets. So evidence have suggested your overnutrition can aggravate your pathogens of diabetes. Evidence have suggested your Mediterranean diet or your low carb diet helps in controlling blood sugar, and there had been a guidelines of food pyramid what has to be eaten in most of the time. And how do you really extrapolate to your day-to-day practice? So here comes your plate method. So this is the diabetes plate method, where your half of the plate should be non-starchy veggies, and quarter plate would be protein, and quarter plate is a whole grain. So the most important catch here is the size of the plate. The size of the plate is supposed to be 9 inches. Some people might have even 15 inches plate, and they would say, sir, I am following a plate method, my sugar is not coming down. So the size of a plate is most important here. And when I say non-starchy vegetables, it is nutrient dense, low in calories and carbs, which could be leafy greens, spinach, broccoli, or cauliflower. When you say lean proteins, which is essential for muscle repair and satiety, and you have chicken or turkey or fish or seafood, anything you can have, and carbohydrate foods, choose high fiber options to slow the absorption. And 50% is non-starchy vegetables, and lean protein is again another 25%, and carbs are another 25%. So we can explain the patient to have a plate method which is 50-25-25 rule. But basically what happens is, in spite of you say all these things, the final word the patient asks is, sir, na dosa sapalama, na idli sapalama. So he is least bothered about your Mediterranean diet. He is least bothered about your evidence. One thing which he can easily understand is a plate size. And once when we see the food, we are also totally confused. So ultimately, it is very, very important for us to understand your basics of nutrition, for us to really counsel the patient or really tell the patient what exactly it wants. So it could be in any form. It could be nuts, it could be egg, it could be bread, it could be fruits or whatever it is. All those nutrients are made up of macronutrient and micronutrients. And of course, hydration is also very, very important, because no nutrition gets complete without your hydration, because you require adequate hydration also. Now, what do you mean by this macronutrients? So these macronutrients, you have carbs, you have fats, and you have proteins. So when I say carbohydrates, you have a monosaccharide, which could be glucose, fructose, and galactose. And you have disaccharides, which is sucrose, maltose, and lactose. But what is more important here is a complex polysaccharides. So you have 3 complex polysaccharide, because the reason why I am emphasizing, and this is even in a plate method, you would say there's a non-starchy vegetables could be taken half the plate, and quarter plate would be cereal. But our basic understanding, everything comes under some form of say carbohydrates or this thing. So in plants, polysaccharide, you have starches, which is the storage form of carbs or polysaccharide in the plants. In animal, what you have is a glycogen. And of course, you have fibers, which is indigestible by the humans, and fibers could be soluble fibers and insoluble fibers. And your soluble fibers are pectins, and the insoluble fibers are cellulose. Similarly, in the starch, what is more important is amylose and your amylopectin. So amylose basically slows your rate of digestion and rate of absorption, so your glycemic peak is less when you take a plant starch which is rich in amylose. So similarly, your polysaccharide content of a particular vegetable or plant what you use determines your glycemic control and glycemic peak of most of the patient. So as I said, the fiber types, you have a soluble fibers which basically dissolves in water, forms a gel-like substance, which could be a oats, which could be a bean, which could be apple, which could be berries. You have insoluble fibers, which basically adds bulk to the food and it supports regularity. Again, you have a whole wheat, nuts, broccoli, and carrots. So as I said before, your soluble fibers, they slows the digestion, they forms gel that delays stomach emptying, and it lowers glucose, reduces the post-meal blood sugar spikes, and it lowers your cholesterol. Similarly, insoluble fibers, it basically adds to the bulk. It promotes your regular bowel movements. So that's the important thing. We have to take it as a whole fruit, because only when you take it as a whole fruit, your insoluble fiber goes into your intestine. When you take as a fruit juice, most of the insoluble fibers are put outside, and you will be taking more and more of nutrient only. So it is always encouraged for our patients to take a whole fruit rather than fruit juices. And your insoluble fiber helps in improving your satiety, so that you feel you have the fullness for a long time. So we commonly tell most of our patients, if you take an orange juice, you require at least 3 oranges to make a 1 cup of orange juice. And கண்டிப்பாக ஒரு 2 டம்ளர் 3 டம்ளர் குடிச்சாதான் நமக்கு அந்த ஒரு குடிச்ச திருப்தியே வரும். So which is equivalent to at least 9 oranges. On contrary, if you take a fruit as orange, ஒரு 2 orange சாப்பிட்டாலே you get your satiety or the fullness. So basically we should try to incorporate as much as insoluble fiber in your food type also. So having said this, you would have seen various numbers here, what is called glycemic index 55 and 30, 36 and various glycemic index numbers. So what is that is the glycemic index. So each food or each carbohydrate has a particular glycemic index. Glycemic index nothing but how fast is your food rises your blood sugar. And glycemic load is slightly different in the sense it depends on your glycemic index into amount of carbohydrate in a particular food. So glycemic load is the speed in which your blood glucose increases into your amount of carbohydrates. So there's a very interesting fact here. Not every food which is rich in glycemic index has an increased glycemic load. For example, you take watermelon, which is very sweet, and the glycemic index is also high, but the amount of carbs is very less in watermelon, so the glycemic load is less. So this means in real life, even the watermelon is sweet, it is advisable to take for most of our diabetic patients. So how do you scale all this thing? Glycemic index, anything less than 55 is called low, anything more than 70 is high, and glycemic load again, anything less than 10 is low, more than 20 glycemic load is supposed to be high. Now when you try to put both your glycemic index and glycemic load in various permutation and combination in your diet, you can have a diet with high glycemic index and high glycemic load, which is definitely very not advisable for our diabetic patient. You can have a patient with low glycemic index and low glycemic load is mostly advisable for our patient. If suppose you want to eat something sweet, you can have food with moderate glycemic index, but your glycemic load has to be definitely low in all these patients. So now, is it possible for me to lower the glycemic load in my meals? Suppose you say, I need rice to eat. I cannot live without rice, because that is something you have been eating for 40, 50 years. So is it possible to reduce a glycemic load of a particular food? It's very simple. You add fiber, you add protein, or you add fat. So it slows the digestion and glucose absorption. That's the reason நம்ம சோறு சாப்பிடும்போது காயை மிக்ஸ் பண்ணி தான் சாப்பிட்றோம். வெறும் சோறா யூஸ்வலி we don't eat it. You have காய் இருக்கும், கூட்டு இருக்கும், whatever it is, you try to mix everything and eat. And cook rice just adequate. குழஞ்ச சாதம் சாப்பிட்டீங்க or overcooked rice increases your glycemic index. So just cooked rice has a lower glycemic index compared to the overcooked rice. So you can add lemon in, and because your citric acid lowers your glycemic index, and cool and reheated starches, it creates resistant starch. So that is one reason பழைய சாதத்தில் வந்து சுகர் நீங்கள் ஃப்ரெஷ்ஷாக வடித்து சாப்பிட்ற அளவுக்கு கூடாது. So that is because when you cool and reheat and do various processing and fermentation, it creates a resistant starch. So though it might be rice, your blood sugar increase may not be that much. So moving from simple carbohydrates, complex carbohydrates, the next important macronutrient in our body is your proteins. So you have various plant-based proteins, various animal-based proteins. I am sure Dr. Chinnadurai sir asked a question on, if I take a chickpeas of 100 gram, how much protein will I get for patients? So if you are taking 100 gram of chickpeas, you may have 7 gram of protein is there at what you would get. So this is absolute protein based on absorption what you would get. So and your protein recommendation again depends on somewhere between 0.8 to 1.2 or 1.8 gram per kg for most of our patient, and it is always advisable to have a plant protein than animal protein, because plant protein has zero cholesterol, it has almost no saturated fat, it is high in fiber, and it has lots of macronutrients compared to the animal proteins. So protein quality and timing for diabetes, you should distribute your proteins 20 to 30 gram protein per meal, and your quality of protein sources, you should have varying quality of protein sources, whether it could be a fish, poultry, or legumes, or whatever it is. Protein and carbs can blunt glucose rise, so always pre-meal protein may improve your post-meal glucose control. So you should always combine protein with this. And in patient with CKD, for chronic kidney disease, discuss individualized protein targets for your patients. So the protein recommendation would be at least 20 to 30 gram of protein per meal. Include protein at breakfast for better glycemic control, and always pair your proteins with carbs to decrease or retard your glucose absorption. Fatty acids, again you have saturated fatty acid, unsaturated fatty acid. Unsaturated you have monounsaturated, or what you call as MUFA, polyunsaturated, what you call as PUFA. So this MUFA and PUFA are supposed to be good for your health, and saturated fatty acid, basically they have no double bond. So any oil which is solid in room temperature is saturated fatty acid. You have butter, you have ghee, you have a coconut oil which becomes solid in in a cold temperature. All those things are saturated fatty acid. What is recommended is monosaturated and polysaturated fatty acid. You can have varieties of oil. You can have say soybean oil, or you can have sunflower oil, or you can have any kind of chicken, whatever it is, but you have varying kinds of oil, so that you will have various MUFA or PUFA for most of your patients. But what is more dangerous is your trans fatty acid. Whenever you reheat your oil, your fat becomes detrimental, whatever it could be. So இப்போ காலையில் வச்ச சாம்பாரை நைட்டு சூடு பண்ணி சாப்பிடக்கூடாது. So which means you heat, cool, and again reheat, whatever fat there becomes bad. So similarly, முந்தின நாள் வச்ச பிரியாணியை மறுநாள் சாப்பிட்றது, or whatever it is, whenever you cool and reheat, your fat becomes bad. So now, having had the basic of this macronutrient, what is carbs, proteins, now it is very easy for us to understand when we come back to a patient. So carbohydrate, you limit your refined sugars for most of a patient, and your carbs should be 30 to 50%. Now if I have this background knowledge of carbs or proteins or fats, now it's very easy for me to counsel my patient or convince my patient what has to be taken. Focus on fiber rich sources. Protein target, as I said, is 1 to 1.2 gram per kilogram. It is to preserve your lean mass. If you have a CKD, adjust or reduce your protein intake. Dietary fat, prioritize MUFA and PUFA, limit your saturated fatty acid, and you have cardioprotective, you can use omega-3 fatty acid, which is available in fatty fish, nuts, or seeds. And your quality matters, minimally processed food and low glycemic index food is very important. And next is a portion category. How much is that? The easiest thing is you can have one fist of non-starchy vegetables, you can have one palm of lean proteins, and you can have a cup of high fiber carbohydrates and one thumb of healthy fats, nothing more than that. And always have a pre-portion snack, drink water before meals, keep food out of your sight, and chew thoroughly, because the chewing is something is very, very important, because chewing your food has benefits in it has adequate salivary exposure, better absorption of nutrients, easier digestion, and it has time to signal the release of leptin. So எவ்வளவு தூரம் வாயில மென்னு சாப்பிட்றோமோ அவ்வளவுதான் it is supposed to be healthy. So அப்படியே முழுங்கக்கூடாது ஃபுட்டை. மோர் யூ சூ பெட்டர் இட் இஸ் ஃபார் யர் ஹெல்த். அண்ட் திஸ் இஸ் கீழே உட்காந்து சாப்பிட்றது அகெயின் இட் இஸ் வெரி அட்வான்டேஜஸ். ஏன்னா ஒரு ஸ்டேஜுக்கு அப்புறம் சாப்பிட்டீங்கன்னா வயிறு தொப்பை தட்ட ஆரம்பிச்சிடும், நமக்கே சாப்பிட்டுட்டு எந்திரிக்க முடியாது. இதே டேபிளில் உட்காந்தோம்னா நம்ம சேரை பின்னாடி நாட்டி போட்டு எவ்வளோ நாளும் சாப்பிட்டுக்கலாம். So always have a habit of eating in the floor, and this is the plate method what we are using before. இலையிலே plate வந்துடுது, 50% இங்கிட்டு தான் ரைஸ் இருக்கும், அங்கிட்டு தான் காய் வைக்க முடியும். So if we go back to previous what we are doing, so it is the exactly the plate method what we have been advising for most of our patient. And meal timing is important, 8 a.m. to 7 p.m. what we call as 8 to 1-7. Breakfast is 8, lunch at 1, and dinner at 7 p.m. Of course, you can have half an hour to 1 hour plus or minus depending on your schedule, but this is how it has to be followed. And step 2 is more important, is you have to integrate with your pharmacotherapy.
if you are having insulin or sulfonylureas, align carb intake with peak insulin action. Whatever insulin you have been using, short acting, ultra short acting, long acting, try to integrate it, educate on hypoglycemia. We have newer GLPs which has appetite suppression, so where you should have a smaller food, nutrient dense meals, protein to preserve muscle mass. Don't take more food at a single time. Whenever you are using SGLT2 inhibitors, avoid ketogenic diet, low carb diet, and educate on sick day rules and increase your fluid intake. And of course, whenever you are using insulin for your patient, there is something called insulin to carbohydrate ratio, so which would really help you to suggest how much carbs you have to take for a particular insulin. So these are also is feasible for most of our patients, and you can have continuous glucose monitoring, which could even suggest what is a postprandial spike, whether you have delayed hyperglycemia or not, and based on that you can try to titrate the food. When you have a CGM and have a nutrition, you know what food peaks blood sugar and when it is peaking, and it is very easy for us to titrate the nutrition. So always your pharmacotherapy has to be integrated with your nutrition, then only we will be able to have a adequate blood sugar control. Just to conclude, your medical nutrition therapy is not static. It must evolve with the pharmacological profile. So whenever patients metformin, you may give a diet, but once when the patient goes to insulin, it has to change. Always choose a whole minimally processed foods. Your primary goal for insulin or sulfonylurea users is to hypoglycemia prevention, and ensure intake despite GLP anorexia, nutrition adequacy should be checked. So whenever patients on SGLT2 inhibitors are in a severe illness, there is a chance of euglycemic ketosis. Safety monitoring is important, hydration is important. Adjust medicines if lifestyle targets are met. You reassess, reduce the medicine or relax the diet for your patients. No single ideal eating pattern exists. Your selection should be individualized based on your metabolic goals and patient preference. And thank you so much.